If I told you that the air you're breathing right now is being aggressively regulated by this tiny passage in your skull, like no wider than a pen cap.
Really, a pen cap, really?
Right, and that to fix this passage when it breaks, surgeons actually occasionally use pharmaceutical-grade cocaine to prepare you for surgery.
Which sounds completely made up.
It really does. You probably think I was describing some wild, I don't know, Victorian-era medical experiment. But this is actually modern ear, nose, and throat surgery.
Yeah, it's just standard practice today.
Exactly. And for this deep dive, we have this massive stack of incredibly detailed, handwritten medical study notes. They cover ENT pathology, anatomy, and all these intense surgical interventions.
They are dense. I mean, really dense.
Oh, absolutely. So our mission today is to translate this dense medical shorthand for you and take you on a guided journey through this hidden, highly complex, and honestly surprisingly fragile labyrinth that is sitting right behind your face.
Because it's a journey that it really completely changes how you view your own anatomy.
Yeah.
I mean, most of us just take our breathing, our sense of smell, and even the basic structural integrity of our faces completely for granted.
Right. You don't even think about it until you have a cold.
Exactly. But these notes reveal the astonishingly precise biological engineering that's required just to, clear a simple sniffle. And perhaps more shockingly, they detail the extreme high-stakes medical interventions required when that delicate engineering actually fails.
Yeah, because when you knock on your forehead or tap your cheekbone, it feels incredibly solid, right?
It feels like armor.
Yeah, it feels like you're walking around in a thick, impenetrable helmet of bone. But looking through these pages, that illusion of a solid fortress just completely shatters.
It really does.
And the notes actually start by outlining the terrifying things that can break that fortress down. I want to look at the medical terminology used here for these bone-destroying pathologies because it is wild.
Medical naming conventions can be pretty creative.
Creative is one word for it.
Yeah.
There are terms like soap bubble lesions and chocolate cysts. I mean, it sounds like something straight out of Willy Wonka, but in the human skull, these are highly destructive.
Yeah, they are.
So what actually is a soap bubble lesion?
Well, it's a classic medical coping mechanism, really.
Okay.
Using everyday visual terms to describe severe pathology. The notes are describing something called a giant cell granuloma.
Okay.
Now, a granuloma is essentially just a cluster of immune cells. Normally, your body forms these to wall off something. They can't easily eliminate, like a foreign body or some stubborn bacteria.
Like a quarantine zone.
Exactly, biological quarantine. But in a giant cell granuloma, this localized immune response just goes completely rogue. It usually happens in the maxilla, so your upper jaw, or the mandible, your lower jaw. And interestingly, it affects females more than males at about a 2-to-1 ratio.
But how does a cluster of immune cells turn into like a soap bubble?
Because the rogue cells start aggressively breaking down the surrounding bone. When you look at it on an X-ray or a CT scan, it doesn't look like a solid tumor. It creates what are called dendritic lesions with well-demarcated edges.
Which means what exactly?
It basically means it eats away the dense bone in these distinct, expanding, bubbly pockets. So it leaves this hollowed-out honeycomb structure that literally looks like a cluster of soap bubbles just trapped in the jawbone.
That is deeply unsettling. And when I see a term like granuloma actively eating into a jawbone, my first thought is that you treat it with intense chemotherapy or maybe radiation.
You're right, that would be the assumption.
But the notes just say the treatment of choice is excision. Are surgeons literally just carving these soap bubbles out of the skull?
Yes, the primary treatment is just surgical removal. You have to physically curette or scrape out the entire bubbly mass of tissue to stop it from expanding any further.
Just scraping it out.
Scraping it all out. And then you often have to reconstruct the missing bone.
Yeah.
But you also mentioned the chocolate cyst earlier.
Right, yeah.
That's the shorthand for a cholesterol granuloma.
Which raises another massive question for me. How does cholesterol, which I usually associate with, eating too many cheeseburgers and getting clogged arteries, how does that end up forming a cyst inside your skull?
It's a very different mechanism. It usually starts with poor drainage and a small bleed within a confined airspace in the skull, like the middle ear or one of the sinuses.
Okay.
So the red blood cells break down over time and their cell membranes degrade. When that happens, they release cholesterol lipids.
Oh, I see.
And since the space lacks proper drainage, these cholesterol crystals just accumulate. The body's immune system recognizes these crystals as foreign and attacks them, which triggers a massive inflammatory response.
So the body is attacking the breakdown of its own blood.
Exactly. And this forms a slowly expanding cyst filled with a dark, thick fluid made of old blood, cholesterol, and fibrous tissue.
Which gives it that dark chocolate appearance.
Unfortunately, yes.
Yeah.
That's the chocolate cyst.
Okay, I'm never looking at a chocolate truffle the same way again. But the pathology in the section that really stopped me in my tracks was the part about cocaine abuse.
Oh, yeah. That section is fascinating.
It's crazy. The notes detail that recreational cocaine causes massive mucosal inflammation, and in 50% of cases, it leads to a septal perforation, meaning it literally burns a hole right through the middle of your nose.
Right, a complete breakdown of the septum.
But then there's this other statistic that seems to contradict everything I thought I knew about, like chemical burns. The notes highlight that 50% of these cocaine abuse cases test positive for PR3-ANCA, as well as human neutrophil elastase.
Yes.
How does a recreational chemical trigger an immunological marker?
This is such a fascinating mechanism because it highlights how external chemicals can completely trick the body's internal defense systems. So ANCA stands for anti-neutrophil cytoplasmic antibodies.
That is a mouthful.
It really is. But they are basically autoantibodies. Now, normally your antibodies are the good guys, right? They attack foreign invaders. Autoantibodies, however, attack your own cells.
Oh no.
Yeah. And testing positive for PR3-ANCA typically indicates a severe systemic autoimmune disease, specifically a type of vasculitis where the body attacks its own blood vessels, which leads to necrosis or tissue death.
Wait, so the cocaine isn't just burning away the tissue like battery acid?
Exactly. It's not just a direct chemical burn. The chronic use of the drug alters the local tissue environment so profoundly that it tricks the body's own immune
It
system.
confuses it.
Totally confuses it. The immune system starts producing these PR3-ANCA autoantibodies, essentially declaring war on the midline structures of the face. It attacks the blood vessels, supplying the palate and the septum.
Wow.
So the body is basically weaponized against itself by the chemical. It destroys the barrier between the nose and the mouth, which can even lead to nasal regurgitation where food or liquid actually comes out of the nose.
So it's not just the drug eating the nose, it's friendly fire.
Rampant friendly fire.
That is absolutely terrifying. But let's step back from these extreme bone-eating pathologies for a second. Because if the immune system can be tricked that easily, it makes me wonder about the everyday functioning of this labyrinth.
Sure.
Let's look at something you, and probably most people listening, deal with every spring: allergies.
Allergic rhinitis is a perfect example of the immune system working exactly as designed, but completely misidentifying the target.
Right, and the notes outline this meticulous process for diagnosing it. You start with skin prick tests to look for specific IgE measurements. Now, I see the term IgE everywhere on allergy meds, but what actually is it?
IgE, or immunoglobulin E, is essentially the body's alarm bell protein.
Okay.
It's an antibody specifically designed to bind to allergens and then signal your immune cells to release histamine and other chemicals.
Which causes all the swelling and the runny nose.
Exactly. So if a skin prick test shows high IgE for pollen, you have an IgE-mediated allergy. The alarm bell is ready to go off the second pollen enters the room.
And the treatments range from oral and topical corticosteroids, like prednisolone, to try and suppress that alarm, all the way up to targeted anti-IgE therapies.
Yes, the heavy hitters.
Yeah. The notes mention a drug called omalizumab for refractory cases, meaning cases that just won't respond to anything else. And omalizumab literally binds to the IgE alarm bell so they can't even ring in the first place.
It silences the alarm entirely.
Right. But to understand why we need these heavy-duty drugs, we have to look at the anatomy of the sinuses themselves. And this is where the notes introduce the osteomeatal complex.
Yes. And the notes explicitly state that the osteomeatal complex is a functional entity, not just a set of anatomical boundaries.
Which is an important distinction.
Very important. I mean, we tend to think of the sinuses as just empty tubes or caves in our head that occasionally get clogged. But they are dynamic functioning ecosystems. They're constantly regulating airflow, warming the air to body temperature, and using this conveyor belt of microscopic hairs to clear mucus.
And the architecture inside this complex is incredibly intricate. The notes mention something called the uncinate process.
Right.
And instead of just calling it a bone in the sagittal plane, which just sounds like boring geometry homework, the best way to visualize it is like a microscopic bony awning, or a gutter inside your nasal cavity.
That's a great way to picture it.
Yeah, it protects the main sinus openings and directs the flow of mucus. is. But the detail that completely blew my mind is the internal nasal valve.
The absolute bottleneck of your breathing.
The bottleneck. The notes say this space is only 15 to 18 square millimeters.
It's tiny.
That is microscopic. Like I mentioned at the very beginning of the deep dive, if you're just sitting there breathing normally, all the air keeping you alive is squeezing through a gap the size of a pen cap.
It really puts things in perspective.
It does. So I have to ask a question on behalf of everyone listening who suffers from hay fever. If this space is only 15 millimeters wide and it is so incredibly critical for our survival, why on earth does the human body risk completely clogging it up with an aggressive allergic reaction to something as harmless as tree pollen?
Well, it really comes down to an evolutionary miscalculation of threat.
Okay.
The immune system in the mucosal lining of your nose is designed to be hypervigilant. Its primary job isn't your comfort, it's your survival.
Right, doesn't care if you have a headache.
Exactly. It's trying to trap and destroy deadly pathogens, viruses, and bacteria before they can reach your lungs, or even worse, breach the barrier to your brain. So when it detects an invader, the standard operating procedure is to trigger massive inflammation and mucus production to just flush it out.
So it's essentially flooding the engine to put out a fire.
That is exactly what it's doing. And the problem with allergic rhinitis is that this hypervigilant system misidentifies harmless pollen as a deadly pathogen.
It panics.
It completely panics. The ensuing inflammation swells the mucosal lining. And because that internal nasal valve is only 15 square millimeters, it literally only takes a fraction of a millimeter of swelling on either side of that tissue to completely shut down the toll booth.
Wow.
Our structural design basically prioritized a highly sensitive filtration system over maintaining a wide open tunnel.
So our own security system shuts down the highway. That's so frustrating. And what happens when the medical treatments fail? Like if the steroid sprays and the antihistamines can't stop the alarm bells and that pen cap toll booth is just permanently swollen shut, do we just have to live with it?
Well, that's when we have to go from chemistry to architecture. We have to physically remodel the toll booth.
Time to break out the tools.
Exactly. This brings us to SES, which stands for Functional Endoscopic Sinus Surgery. And the goal here isn't just to blindly carve out bone, but to surgically restore the natural drainage pathways of that functional ecosystem we talked about.
And the preparation for the surgery is wild. The notes describe the use of something called Moffitt solution for topical anesthesia and decongestion before the surgeon even makes a single cut.
It's quite the cocktail.
You're not kidding. The ingredients are 2 milliliters of 8% cocaine, 2 milliliters of sodium bicarbonate, and 1 milliliter of adrenaline.
Yes.
Wait, we literally just spent time talking about how recreational cocaine destroys the nasal septum and triggers autoimmune vasculitis. But here, pharmaceutical cocaine is the exact tool used to prepare the nose for delicate surgery.
It is.
How does the tissue know the difference between the destructive drug and the helpful medicine?
It's a striking contradiction for sure, but it really comes down to pharmacology versus chronic abuse.
Okay.
You see, cocaine is completely unique among local anesthetics. It is both a potent numbing agent and a profound vasoconstrictor, meaning it aggressively shrinks blood vessels.
And why is shrinking blood vessels so important here?
Because when a surgeon is operating endoscopically in a space of millimeters, bleeding is the absolute enemy. Even a few drops of blood can completely obscure the tiny camera lens.
Ah, so the cocaine stops the bleeding before it even starts?
Precisely. Moffitt's solution drastically shrinks the swollen mucosa, opening up the visual field for the surgeon while simultaneously numbing the tissue and clamping down all the capillaries.
Wow.
And the recreational destruction you mentioned earlier, that septal perforation, that's the result of chronic, repeated, unregulated exposure.
Right, doing it every day.
Exactly. That constant vasoconstriction stars the tissue of blood until it literally dies from ischemia. But in surgery, it's a controlled, heavily diluted, one-time application designed purely for precision access.
Okay, that makes sense. So the blood vessels are clamped, the camera is in. Now they perform what the notes call anthrostomies, basically creating or enlarging openings. And the notes list these in escalating severity. Type 1 is just expanding the natural opening to an ideal 1 by 1 centimeter square. But type 3 takes the opening completely down to the nasal floor.
It's a significant remodeling.
Yeah. But then we get to the frontal sinus approaches, which the notes refer to as the draft procedures.
Yes. Accessing the frontal sinuses, which are those hollow cavities right behind your forehead, is notoriously difficult.
Why is that?
Mostly because of the harsh angles involved and their immediate proximity to the brain and the eyes. You have to be incredibly careful.
The notes list these out, but I want to make sure we actually understand the mechanism. So draft eye is an anterior ethmoidectomy. What exactly is a surgeon removing there?
So imagine a fragile, bony honeycomb situated right between your eyes.
Okay, got it.
Those are the ethmoid sinuses. An anterior ethmoidectomy involves carefully breaking down the delicate walls of the front portion of that honeycomb. This creates a single, larger cavity, which then clears the way to the frontal sinus drainage pathway sitting just above it.
Got it. It's like knocking down a few interior walls. And if that's not enough, they move to draft the eye, which the notes literally describe as uncapping the egg.
I love that description. That phrase perfectly captures the visual.
This is so vivid.
It is. The frontal sinus drains downward through a very narrow bottleneck. And often there is a specific, naturally occurring air cell called the Aguirre-Nasse cell that sits right in that drainage pathway.
Blocking it.
Exactly, blocking like an egg sitting in an egg cup. So the surgeon has to delicately shave off the top half of this bony cell to uncap the egg without damaging the surrounding mucosal lining. This allows the frontal sinus fluid to finally drain straight through it.
That's incredibly precise. And if the egg is uncapped and the honeycomb is cleared and the patient is still blocked, the notes detail draft third.
Yes, that's it.
An endoscopic modified Loeffler procedure. This involves drilling out the entire frontal sinus floor, the intersinus septum, which separates the left and right forehead sinuses, and the superior nasal septum.
It's a massive procedure.
They are basically taking a sledgehammer to the interior walls to turn a bunch of small clogged rooms into one giant maximum drainage cavity.
It really is a major architectural remodeling of the skull base.
Yeah.
And because of the trauma involved with all that drilling, the notes also mention a less invasive alternative, which is balloon sinus dilation.
Oh, like a stent for your nose.
Sort of. Instead of drilling out the bone, they insert a tiny deflated balloon into the blocked opening and then carefully inflate it. The pressure of the balloon fractures the microbones outward, permanently widening the space without actually removing any tissue.
And the stats for the balloon are actually really impressive. Patients see a 67% symptom improvement at 6 months, and 85% at 1 year still maintain that open airway.
Those are great numbers.
Which makes total sense why a surgeon would prefer a balloon over a drill. Because the moment you start aggressively knocking down walls inside the face, the stakes become astronomically high.
We are definitely entering the danger zone at that
That's
point.
okay.
The major complications of FESS listed in these notes emphasize just how close the surgeon is operating to critical structures. You have orbital injury, optic nerve injury, which means permanent blindness, and CSF rhinorrhea.
CSF rhinorrhea, that's cerebrospinal fluid leaking out of your nose.
Yeah.
The clear fluid that bathes and protects your brain is literally dripping out of your nostrils because the surgeon went, what, a millimeter too high?
Just a millimeter.
We think of our brain as being locked in this impenetrable vault, but these notes show that there is literally only a paper-thin barrier of bone separating the dirty, fungus-prone environment of the nose from the completely sterile fluid of the brain.
It's terrifying when you think about it. That barrier is called the cribriform plate. It forms the roof of the nasal cavity and the floor of the brain cavity.
Okay.
And it is incredibly thin, and it's naturally perforated with all these tiny holes for your olfactory nerves to pass through, which gives you your sense of smell.
Which is already full of holes.
Exactly. So during the draft 3 procedure, if a surgical instrument breaches that plate, you have created a direct conduit from the non-sterile outside world directly into the brain cavity.
And managing a CSF leak sounds like an absolute nightmare. The notes say it requires a lumbar catheter to constantly drain fluid from your lower spine just to reduce the pressure in your head.
Yeah, you have to lower the intracranial pressure.
You need strict bed rest with the head elevated. You absolutely absolutely cannot cough, sneeze, or blow your nose. And they pump you full of prophylactic antibiotics, specifically ceftriaxone, to guard against streptococcus pneumonia and Haemophilus influenza.
Yes, very specific targets.
Why those specific bacteria?
Because those bacteria are common, opportunistic colonizers of the upper respiratory tract. Usually they just hang out in your nose or throat, causing minor issues, if any.
Right, everyday bugs.
But if there's a hole in the cribriform plate, they suddenly have a back door directly to the meninges, the membrane surrounding the brain. The immediate life-threatening risk of a CSF leak is rapid onset bacterial meningitis.
Wow. And if the leak won't close on its own, it requires surgical repair.
It does.
The notes outline a very specific layering technique for the repair. It sounds like patching a crack in a pressurized submarine hull. You put fascia connective tissue on the intracranial side inside the skull, then you place bone or cartilage on the outside.
A multi-layer patch.
But there's a massive, heavily underlined rule here in the notes. Mucosa grafts should never be placed inside the defect. Why is that specific tissue so incredibly dangerous to use as a patch?
It's a brilliant but terrifying surgical principle. Mucosa is the specialized tissue that lines the respiratory tract.
Right.
It constantly secretes mucus and has those microscopic hairs, the cilia, to sweep that mucus along.
Right.
If a surgeon mistakenly places a mucosa graft inside the cranial cavity facing the brain, that tissue will survive, and it will just keep doing what it is programmed to do.
Oh no.
It will continue to secrete mucus and shed dead cells directly into the enclosed brain cavity. And because the mucus has nowhere to drain, it forms a deadly, slowly expanding mass called a mucocele.
Inside the skull.
Inside the skull, physically compressing the frontal lobe of the brain.
So if you use the wrong material, the patch itself floods the submarine.
Exactly.
That is incredibly precise. But surgical errors aren't the only thing that can breach this paper-thin barrier. The notes dive into fungal chronic rhinosinusitis, and this is just pure nightmare fuel.
It really is.
I know fungal infections are different from bacterial ones, but why are they so much more dangerous in the sinuses?
Because fungi behave structurally and biologically differently than bacteria. They don't just multiply in the fluid like bacteria do. They build actual physical networks.
Okay.
The notes differentiate between two major types of fungal invaders, and the microscopic shape of the fungus dictates exactly how it will kill you.
Okay, the notes mention Aspergillus, which is characterized under a microscope by septate hyphae branching at 45 degrees.
Yes.
But then you have the Xitomycetes, specifically mucormycosis, and the notes state plainly this is more virulent. Under the microscope, mucormycosis consists of non-septate ribbon hyphae branching irregularly.
Right.
I have to push back here for a second. Why does the physical shape of the fungus, whether it branches at 45 degrees or looks like a ribbon, matter so much to the patient?
The structure is the mechanism of invasion. Aspergillus, with its neat 45-degree branches, and septa, which are little cross walls within the fungal tubes, can cause severe allergic reactions and form this thick, peanut buttery mucin that clogs the sinuses.
Gross, but okay.
It's bad, but it's mostly contained. Mucormycosis, however, has non-septate ribbons. It lacks those internal cross walls entirely.
Which means what?
This allows rapid streaming of nutrients through the entire fungal network, powering a much more aggressive growth.
It just grows way faster.
Faster and much more destructively. Because it lacks those walls, it exhibits something called angioinvasion. It doesn't just sit in the mucus, it actively invades the walls of your blood vessels, literally choking off the blood supply to your own tissue.
Oh my god.
The surrounding flesh literally dies and turns black from ischemia. And because it travels along the blood vessels, it can rapidly bypass the bone and spread from the sinuses directly into the eyes and the brain in a matter of hours.
Just hours. The notes mention that on a CT scan, fungal infections uniquely show a double density. It's this opaque area with an even denser center due to the heavy metals like iron and manganese that the fungus actively accumulates from the host environment.
Yes, it hoards metals.
It's like seeing the dense armored core of an invading army right there on the scan. In those cases of mucormycosis, aggressive surgical debridement, literally scraping away all the dead black tissue, is the only chance of survival.
Exactly. You are racing against an organism that is actively eating the vascular highway to the brain.
So we've established the extreme adult surgeries, the paper-thin bones, and the deadly fungal invaders that can choke off your blood supply. But then the notes completely pivot. We realize that everything we just discussed only applies to adults. When the patient is a child, this entire rulebook gets completely thrown out the window. If the architecture is roughly the same, why are the rules so different?
Because pediatrics is not just internal medicine on scaled down humans. A child's labyrinth is actively under construction, and the architecture is fundamentally unfinished.
Which changes the entire pediatric CRS management algorithm. The notes say you always start with maximal medical treatment antibiotics, intranasal steroids, saline irrigation.
You try everything else first.
Everything. And if symptoms persist for more than 12 weeks, then you finally get a CT scan. But here's the massive difference. Unlike adults, where FASS, the drilling and remodeling, is a standard option, in children, an adenodectomy is the first line of defense.
Yes.
Why are they removing tissue in the throat to fix a problem in the nose?
Well, the adenoids are a pad of immune tissue high up in the throat, right behind the nasal passage. In children, they are highly active and often very large. Because of their location, they frequently act as a biological reservoir, harboring the exact bacteria causing the chronic sinus infection in the first place.
Oh, I see.
Removing the adenoids essentially removes the source of the contamination. It boasts a 50 to 80% success rate in resolving chronic sinus issues, allowing doctors to entirely avoid operating on the sinuses themselves.
Which they desperately want to avoid because FES in children is highly restricted. It is reserved only for resistant cases or children with cystic fibrosis or severely decreased immunity.
They do not want to drill if they don't have to.
And the notes list out the anatomical reasons why children are so vulnerable. They have thinner bone walls with porous septa, they have open suture lines where the skull bones haven't fully fused yet, but the detail that really highlights the danger is the diploid veins of Burchett. What are those?
These are specific veins that run within the skull bone itself. The critical detail here is that the veins of Burchett are completely valveless.
So it's like a plumbing system with absolutely no backflow preventers.
Precisely. In a normal vein, valves ensure blood only flows in one direction. Because these veins lack valves, blood, and therefore any bacterial infection can easily flow backward depending on pressure changes.
That sounds incredibly dangerous.
It is. In a child whose bones are already porous and unfused, all these factors mean that a simple, stubborn sinus infection has a direct, unrestricted highway system right into the orbit of the eye or into the brain cavity. It can lead to orbital cellulitis or a brain abscess incredibly fast.
It makes complete sense why surgeons are so hesitant to drill. You don't want to bring sharp metal instruments into a delicate, highly porous construction zone, where the brain is just on the other side of an unfused bone and the plumbing system has no backflow valves.
Exactly. You would be risking severe damage to the developing anatomy and opening massive pathways for devastating infections.
What an unbelievable journey these notes have taken us on. We started with the illusion of a solid skull, only to find giant cell immune responses eating the jawbone into soap bubbles.
And chocolate cysts.
And chocolate cysts. We discovered the profound irony of recreational cocaine tricking the immune system into friendly fire, while pharmaceutical cocaine acts as the ultimate surgical tool.
A true paradox.
We zoomed into the 15mm internal nasal valve, the microscopic toll booth of our breathing, that our own hypervigilant immune system swells shut over a single grain of pollen.
All for our protection.
Right. We visualized uncapping the frontal sinus egg, patched pressurized brain fluid leaks from the inside, and dodged ribbon-like fungal invaders actively choking our blood vessels. And finally, we saw how a child's unfinished valveless plumbing system completely rewrites the rules of surgery.
It really is a masterclass in biological engineering, but also in extreme vulnerability.
Absolutely.
If we look at one final overarching concept in these notes, it brings this entire paradox together perfectly. Throughout the notes, there's constant reference to the extensive pneumatization of the human skull.
Pneumatization, meaning what exactly?
That means the evolutionary formation of air-filled spaces. We talked about the ethmoidal honeycomb, but there are also Haller cells that pneumatize right into the floor of your eye socket, and Onodi cells that grow intimately close to the optic nerve.
So our skulls aren't thick helmets at all. They are essentially honeycombed with these intricate, hollow pockets of air.
Yes, and evolutionarily speaking, this structural design serves two massive benefits. First, it significantly lightens the physical weight of our large heads, making it possible for our relatively thin necks to support them and allowing us to walk upright.
Okay, that's a big plus.
And secondly, these hollow chambers act as acoustic resonators for our voices, giving human speech its depth, projection, and nuance.
So we traded solid bone for hollow acoustic chambers, but based on everything we've just discussed, Look at the extreme cost of that trade.
That is the lingering question these medical notes really leave you with. Considering the incredible life-threatening risks we just covered, the fact that a localized fungal infection can track right along a hollow noddy cell to permanently blind you in hours, or that a simple allergic reaction can trap fluid next to a paper-thin wall of bone separating the dirty outside world from your sterile brain fluid.
Yeah.
Was the evolutionary benefit of a lighter head and a resonant voice truly worth the cost of building such a fragile, highly infectable labyrinth right behind our eyes?
Next time you tap your forehead and take comfort in that solid fortress, just remember the microscopic, delicate, and deeply vulnerable world that's really hiding underneath.